everyone, this is Dr. Yoki. I'm really excited about today because I'm currently on my neurology consult service rotation, and I'm really excited to be bringing you all along with me to show you what it's like to be on the neurology consult service. So first and foremost, neurology consults is very different than inpatient neurology for many reasons. One of the main reasons is that there is a primary team responsible for the patient, and it's not the consult service. It's just whatever primary team is requesting the consult. And on the consult service, you give your recommendations, you evaluate the patient, you answer a specific question that the primary team has for the consulting provider. And then the primary team decides whether or not they want to accept those recommendations and follow those recommendations. So the good part about being on the consult service is that you don't have to see the patient every single day unless they're very, very sick. You usually just have to see them a few times, if that, provide your recommendations, answer the question at hand, and that's it. So my day usually starts at around 10 a.m. and it ends at around 6 p.m. unless I get a late consult, in which case it will end at around 7:30 p.m. the latest. I usually don't see any more than 3 new consults a day. Usually it's around 2. On a really busy day, I might have to see 3, but that's usually what the day looks like for me. And I'll show you guys in a second the first thing I do when I go in on my neurology consult rotation. So the first thing I do when I come in the morning is I log into the EMR. So any patient that's already been staffed on the neurology consult service don't necessarily need to be seen again in person, but they do need follow-up, of course. So what we do is we look at the chart, we look at the progress notes from the primary team, we look at the vital signs, any lab results, just to make sure that the patient is improving and that our recommendations are helping the patient. Important things to follow up on, of course, are things like EEG. Is the patient having any epileptiform discharges, or in other words, seizures? Other things that we look at is any brain imaging, any lumbar puncture, CSF findings. All of that I need to make sure that I follow up with on a timely manner so that nothing gets missed. So yeah, that's pretty much what my mornings look like on neurology consults. It's all on the computer, but that's not necessarily a terrible way to start the morning if you ask me. My first consult usually comes at around 12 or 1 o'clock.
So we'll start with James, Mark, Stephanie.
Dr. Nesbitt, during the...
All right, so we're gonna go see this patient in the emergency department. This older patient came in with vision loss in one eye. Not complete vision loss, but her visual acuity, which means that her ability to see things is less. She was referred from an ophthalmology clinic, so an eye specialist, because her vision really got a lot worse over the past few weeks. So patient's being referred now to the emergency department for a neurology workup, and you'll find out what's going on. So I just finished seeing the first consult of the afternoon. Let me actually just take this off, get settled in. So the first consult question was for a patient who I already kind of described to you guys while I was on my way to the emergency department. This patient had progressive vision loss in one eye. So I obviously can't reveal the details of the case just to protect patient privacy. But what I can say is my thought process for how I'm going to go about this case. One of the most scary things you want to rule out in a patient who has vision loss in one eye and also who's older is giant cell arteritis, which is an inflammation of the temporal artery, and this can lead to permanent vision loss, so you definitely want to rule that out. One of the ways in which you can rule it out is get an ESR, and a temporal artery biopsy. Now for this particular case, I have a low suspicion for that because the patient didn't have other signs or symptoms for that, including like tenderness over the temporal artery. They also didn't have any jaw claudication, which just means that their jaw after chewing for a certain period of time either hurts or kind of gets very tired. So they didn't have any of those symptoms. And also the person already had an ophthalmology exam, which ruled out any kind of signs of ischemia. So lower threshold or lower on the differential. Another potential cause for this patient's vision loss could potentially be optic neuritis, which is just inflammation of the optic nerve. And usually the only way to really see if they're having that is to get an MRI of the brain. So I'm certainly going to recommend that for this patient. A lot of things can cause optic neuritis, for example, multiple sclerosis, NMO, and a number of other autoimmune diseases can cause that. Another finding on exam that could lead you to this diagnosis is having an afferent pupillary defect, which just means that when you shine a light in the opposite eye, the other eye does not constrict. So normally, if you shine a light in the pupil, the opposite one will constrict. But the patient in this case didn't have that. So that is concerning for maybe inflammation of the optic nerve. So we'll see what the MRI shows. Another thing that you want to rule out in someone who has progressive vision loss in one eye is central retinal artery occlusion, which is when someone gets either an emboli that travels through the internal carotid artery, and then that leads to the artery that supplies the eye, or they have internal carotid artery stenosis, which can cause that as well, which reduces the blood flow to that area. That is less likely in this case because the patient's vision loss is more progressive. It wasn't all of a sudden, which is what you would expect in central retinal artery occlusion. It's more all of a sudden, painless, and you would have severe vision loss, not progressive over time. So that's really my thought process for this particular case. We'll see what those images show, and then we'll provide more recommendations based on that. But that was the first case. Very interesting. Really interested to see what this patient actually has and how we're going to manage it. So I actually forgot to mention that Neurology Consults is an entire team of residents. It's not just me. Usually there is a psych intern, and I'm obviously the psych intern on service for the next 2 weeks. But there's also either 2 or 3 other neurology residents, and they range from either first-year residents, second-year residents, or third-year residents. And then there's a senior who is essentially in their 4th year in their last year residency, and they pretty much run the whole service. They assign cases to the other residents. They supervise our work. They let us know what other recommendations and things that we can do for the patients that we're getting consulted for. Yeah, so it's not just me. Just wanted to put that out there. So I've already seen 1 consult, and any consults that come throughout the day, we have to staff them with the attending by around 2:30 p.m. I've already rounded with the attending. We've seen all the new cases and any follow-ups that needed to be talked about. So any consults that we get after we round, which we finish at around 3:30 from rounding, or 4 o'clock, depending on how many patients we see. Any consults that come after that get staffed in the morning with the new attending in the morning. So I've already gotten the second consult of the afternoon after rounds, and the consult question was for altered mental status. Altered mental status is a very common consult question in the inpatient service, and it's very broad. It could be a lot of different causes for altered mental status. It could be toxic metabolic, because of course your brain, in order to function correctly, needs like the appropriate balance of electrolytes. It needs, oxygen. It needs blood flow. So patients that are in the hospital, sometimes they're here for an infection. Their blood pressure could drop. They could have really severe elevated temperatures, which can certainly cause altered mental status. Or they can even have delirium, which in that case, there might not be any metabolic or electrolyte abnormalities, and just being in the hospital can have really negative consequences on someone's attention and mental status. As a neurology consult service, we want to rule out anything that's really scary. So major stroke, that can be a really devastating reason why someone's having confusion and not acting like themselves. So we definitely want to rule out stroke. And you don't necessarily always need imaging for that. You can just examine the patient. Is there any other evidence that they might have had a stroke? Do they have weakness on one side? Are there any cranial nerve deficits? So all of these things pretty much will give you information on whether this person is having a devastating stroke or maybe some other cause. Another common neurologic reason why someone could be altered, not acting like themselves in the hospital, is, of course, seizures. This is another really big reason. Again, all the things that I mentioned before could contribute to lowering the seizure threshold, which just means it makes it easier for someone to have a seizure in the hospital. So if there is a clinical concern for seizures, we recommend that the patient is placed on EEG, which measures the brain waves and gives us an idea of if they're having any epileptiform discharges that we can see on EEG and then diagnose that as a reason for why they're having altered mental status. And lastly, one of the scariest things that we want to rule out, in addition to just a stroke, seizures, forgot to mention, it's not only ischemic stroke, hemorrhagic stroke. So not just stroke, seizures, but also any infections in the brain. So encephalitis, meningitis, very scary, very deadly. We want to rule that out as well. Again, you don't have to do a lumbar puncture, which is what is usually used to diagnose that, in order to rule out any infection in the brain. Again, you rely a lot on your exam. I think that's one of the things that I really like about neurology is you rely really heavily on your exam to guide you to one direction or another, whether you need a certain test, whether you don't need a certain test based on what you find in an exam. That's one of the things that's really interesting about neurology is you can tell a lot about a patient's neurologic exam. And then let's see if there's anything else I can think of. Medications. Medications are another big reason why someone can be altered in the hospital. So it's a very broad differential diagnosis. So once I go see this patient, I'm gonna obviously do my neurologic exam and rule out any of those major causes for altered mental status. So I'm almost done for the day. It's almost 6 o'clock, but I wanted to show you guys this beautiful view from this window through the bridge. And the sunset, of course. It's very nice view. So that's it for me. I'm done for the day. I hope that gives you guys an idea of what it's like to be on neurology consults. The workload is a lot less than you would be doing on the inpatient neurology wards, which is why I like neuro consults. The work day is also a lot shorter. Usually I only work, like I mentioned, 10 to 7 or 10 to 6 at most. In patient wards, you can work anywhere from 12 hours to 16-hour days. So it's a lot less work on neuro consults. And you get to see a lot of really interesting cases on neuro consults. For example, I had previously seen a case of a patient who was psychiatrically hospitalized and we were consulted on because the patient was having myoclonic jerks. It turned out this patient's psychiatric presentation and her myoclonic jerks were consistent with autoimmune encephalitis. After she was on EEG, was discovered that she was having seizures. She got an LP. Turned out to be autoimmune encephalitis, which is kind of scary to think about, that the patient was in the psychiatric ward as opposed to the neuro ward. But thankfully in the end they got the diagnosis right. It's kind of like that case on Brain on Fire, the movie. I don't know if you guys ever seen that. I absolutely love that movie. It's one of my favorite movies. If you haven't seen it, I recommend it. But yeah, a lot of really interesting cases. So thank you for joining and see you next time. Bye.